My name is Ryan Pferdehirt. I am a bioethicist with the Center for Practical Bioethics in Kansas City, Missouri, and I'm also a professor of bioethics at Kansas City University Medical School. I teach in the master's program and also bioethics to our core class. What is a bioethicist? I am philosophically trained. I have degrees in philosophy, specializing in bioethics, but I've also worked my entire career in the clinical setting. Before being in Kansas City, I was in the Seattle area for a multi-hospital health system. And now here in Kansas City, I work with many different hospitals in the area, covering about 24, 25 different hospital systems. What I do is I do inpatient consultation. So I work with patients, I work with families, I work with physicians who are struggling with some very challenging clinical ethics situation. We'll get into what could be a clinical ethics situation and how NDEs can be impacted by that, and how with my approach specifically, how we would address this type of thing. And we're going to go a little bit into some of the philosophical underpinnings of how we address this and where our value comes from. And then also, how do we address this? How do we move forward? And then some fundamental important aspects of addressing these types of things. Okay, announcements and housekeeping. I have to state, I have no conflicts to report, and I am not personally receiving any payment for this presentation. If an honorarium is being provided, it will go directly to the Center for Practical Bioethics, which is a non-profit entity that covers healthcare ethics, education, and support for families and physicians and medical providers dealing with ethical issues. So I just want to put it out there that I am not conflicted. So first, I want to address what we call everyday philosophies. And for the beginning of this is an article by Jeff Bishop, who's out of St. Louis University, who wrote an article about everyday philosophies. Physicians are inept at engaging with near-death experiences. They're not necessarily completely understood, and they're also very challenging situations. They are, more importantly, they're extremely personal experiences. We're going to go into some of these ideas of phenomenology, but we really experience life as an individual, and we can't necessarily share those experiences because everything has to be experienced by that person. So how do we engage with patients in that way? How do we speak to them where all of this information is an extremely personal experience? So what we use is what we call everyday philosophies. And what these are background beliefs, background concepts. They are how we live through our lives. We believe that the sun is going to rise. We believe that the wind will blow. These are not necessarily things that need to be proven every single day. It's kind of these underpinning understandings that we just accept and we engage with, and we build our understanding of the world and how things are experienced based off these underpinnings. Think of them as like mathematical axioms within geometry of these are our core beliefs, these are our core understandings, and this is what we think. And whenever the problem becomes, what happens whenever they become challenged? Whatever we have an experience that is not necessarily within our everyday philosophies. Well, there's four options that Bishop outlines. We can either deny the experience. We could say that that is not real. It didn't actually happen. We can say that what the experience was doesn't matter and that it wouldn't be there. Or we can compartmentalize. That's saying we have our core beliefs, but this exists outside of those core beliefs. It's not necessarily a denial of that experience, but it's kind of putting within context, putting within our understanding so that we can more easily process that information. Or we could reject that information. We could reject that experience. We could say, such as a near-death experience, that that is not real, that it didn't actually happen. If it doesn't fit within our everyday philosophies, we could just say that doesn't work, or we could reject the everyday philosophies. We could say that what we had as our core beliefs, because they're being challenged, we're just going to throw those out. So kind of the opposite of denying the experience, which is throwing out the experience because of philosophies, this would be throwing out those philosophies based off that experience. Or fourth, and this is what Bishop really recognizes as probably the best option, is acknowledging that our philosophies fall short, acknowledging that we can't necessarily explain everything that we understand or everything in the world by our core philosophies, that things will change. And I think that this is one of the most important aspects of human experience, is how we build our understandings and how we need to be accepting of the changes and of those experiences. There's debates within philosophy of rationalism versus empiricism, which is experiences. Do we think that things should be thought through and understood? That would be really focusing on the philosophies and trying to build our understandings, focusing on that versus focusing on the experiences. And whenever science and human understanding is, I believe, in perfect harmony with each other, is whenever the two are harmonized between the two. So an example would be in ancient Greek culture, Hellenistic culture, they knew that the earth was round. They figured it out. And we talk about Columbus having done that, but that's kind of a myth. We really knew that the earth was round. And the way they figured that out was when ships were sailing away from harbor, the last thing that they would see would be the top mast of the ship. And versa, whenever they were sailing to harbor, the first thing that they would see would be the mountains and then the highest point of the cities, and then the rest would come down. The only way that they could explain that was that the earth was round. So if they had an everyday philosophy of the earth being flat, this would challenge that everyday philosophy. So what could they do? They could either deny the experience, which would be saying, oh, we saw the highest point of the city first, and then the rest of the city came up. That doesn't make any sense. Well, we could just say we didn't see that correctly. They could compartmentalize it. Maybe it was just for that city. They could reject the philosophy, which would be saying that, okay, the earth is round, maybe it's not round, or they need to acknowledge that the philosophy falls short, which is saying, okay, this doesn't explain this in this situation. Maybe we need to adjust that. And that's how science really moves through. So what are our everyday philosophies within healthcare? We use science a lot. And I think science gets this grandiose reputation of being able to figure out everything, but we also have to understand our limits of science. What was scientific fact 1,000 years ago, 2,000 years ago, versus 50 years ago is always changing. We're always getting new information. We're readjusting concepts. This is seen with like our theories with particle physics and quantum physics, and also like astrophysics. Things that challenge our core beliefs of gravity and electromagnetism need to have those theories adapted, need to have them changed. And another aspect is what we call reductive science, where we try to take an experience or try to take information and break it down to the lowest part possible, and then build up that experience from there. There's a famous philosopher, Thomas Nagel, who said, he wrote an article called "What Is It Like to Be a Bat?" And he says that if we were to use reductive means to build an experience of what it would be like to be a bat, we would never really be able to experience that, because the experience of a bat is fundamentally different than the experience of life as a human, in that if we break things down reductively, we're not actually achieving an understanding of that experience of a bat. We are achieving our understanding of what humans think it would be like to be a bat. So it's kind of like proving itself by not proving itself, which means we're never going to be able to reach that satisfactory conclusion. And I think that this is what the healthcare community does a lot of times with near-death experiences, is we try to compartmentalize and reduce these ideas down into understandable concepts. This would be like a neurologist looking at brain patterns for a near-death experience. And what we're seeing, and what I believe, is that that is falling short. It's limiting actually our ability to understand that. So what can we use? And this is a branch of philosophy called phenomenology. So phenomenology is the study of structures of experience, of consciousness. It derives from the study of phenomena. And it's a study of the structures of consciousness as experienced from a first-person view. So the idea of phenomenology is the way we experience our lives is the most important thing. It's not necessarily about the objective larger truth, but it's more about the study of individuals. We do a lot of work in healthcare with the phenomenology of pain, and I'm going to use a lot of the research that we've used with pain experience. What is it like for a patient to experience pain? Well, we don't really have any objective truth statement ideas of what pain really is or how it's experienced. Pain is really experienced subjectively. The way I may experience stubbing my toe may be fundamentally different than the way you experience stubbing your toe. For me, it may be the most profound pain I've ever experienced. For you, it's just a nuisance that you can move on with the rest of your day for. But it really matters is is it wrong for me to be saying that stubbing my toe really, really hurts me versus comparing it to someone where it doesn't? And that's what phenomenology is saying, that to me, it is meaningful. To me, it is impactful. And to me, it does bring more pain. And therefore, that pain is more real than to somebody else who may experience it differently. And the central structure of experience is intentionality, it being directed towards something. How do we experience a particular event? So we don't just experience the world from all of it all at once, it's individual actions. And we really study how those individual actions, going back to the pain example, the patient in the critical care unit experiencing that pain, we don't focus on all the things that they could be impacted by, but we focus very specifically on the individual pain. So we want to look at one of the most famous phenomenologists is Edmund Herschel from the 1800s, and he really studied intentionality. And it's the reflection of an experience of an acting agent, an experience that transcends defining objective truth statements that exist outside of that agent. So we're trying to understand what is true outside of the individual. This kind of goes into Descartes argued that I think, therefore I am, one of the most famous lines in philosophy. What he was saying is, I'm experiencing the world. I'm a thinking thing, and I know that there is something contemplating itself, so I'm proving my existence because there must be something there doing the contemplation. So the rest of the world may be a simulation, but he knows that he is real, which means the experiences that he's having are more real. So the focus of an intentionality statement is the agent itself. It really puts the individual person of the objective reality rather than the larger aspect. So what are those aspects of an intentional action? Well, when we're looking at an action to see if it is true from a phenomenological perspective of Herschel, we want to know who is performing that action, what is that person doing, what is that act about, and in what manner is that object of the act. So we'll go into that. So an example is a ghost in the room. I studied philosophy of language. So we really like language statements, truth statements to really define this. So imagine the statement, Michael thought that a ghost was in his room. Is this a true sentence? Is this a true sentence within the reality of the world? Well, it's hard to tell. Let's go through a phenomenological description. This is a complete description of an intentional act. Michael is the one performing the act. Michael is thinking, he thought, what is he thinking about? He is thinking about a ghost. And in what manner is he thinking about a ghost? He is thinking that the ghost is in his room. This is objectively, through this perspective, a true statement. It has a truth value. That's how we describe it. It is a true truth value of that statement. Compare that to a sentence such as, I wrote and sent an email with my phone. Is this a true sentence? What is the truth value of that sentence? Well, the second aspect is actually false. It's invalid, because, forgive the logic of this, if you don't have a phone, then the truth value of the sentence is false of the second aspect, because it would make no logical sense to say, I wrote and sent an email with my phone, but I don't have a phone. So the idea behind this is a logical construction of the fact that the experience of the individual creates the truth value of that statement. Michael thought that a ghost was in the room. That is a true sentence, objectively, but that doesn't mean that there has to be a ghost in his room. That doesn't mean that that reality of the scenario has to be true. The experience of the individual towards that reality creates the truth of that reality. And that's the important thing that we need to consider, is that the true value creates that. So what is bioethics and how do we use this? There's what we call the principles of biomedical ethics. Those are autonomy, which is patient self-determination. This is one of the most fundamental aspects of patients have a right to understand and make their own decisions. We cannot force a patient to have a surgery that they don't feel is proper. We cannot force a patient to engage with therapy that they feel that they do not want. This goes into a larger section of capacity and understanding and contemplation, and does a patient really able to be informed and understanding of the decisions that they're making? Compare that against the other principles, which are beneficence, the obligation of medical providers to do good. We have a responsibility to promote goodness into the world. Also, non-maleficence, the obligation to, it means primum non nocere, means first do no harm. We have an obligation as medical providers to not do harm to patients. And then the principle of justice, of treating equal patients like. Being able, if we have patients who are of different socioeconomic status, different understandings, different genders, we treat everyone the same within like scenarios. The healthcare that a male would receive would not necessarily be the same healthcare that a female will receive, but all females will receive the same care that we provide for females. So treating like patients like, or how we describe that. So a lot of my work within clinical ethics is upholding all four of these principles. We always want these four principles to be valued and done within all patient situations. There's a famous example by Al Johnson that says, say you have a patient complaining of painful urination. Patient goes to the clinic, becomes prescribed with an antibiotic, gets diagnosed with a UTI, gets an antibiotic, fills that antibiotic at their local pharmacy, pays a $1 copay, takes that antibiotic for 3 weeks, and is cured of their UTI. All four ethical principles were upheld. All four were seen through completely. The patient chose to participate in care. The physician did good for that patient. The physician did not do harm to that patient, and justice was upheld. Now you can manipulate that scenario a little bit to create conflict between the principles. And that's where we have what are called clinical ethics situations, clinical ethical dilemmas. What if the patient is a naturopathic person and doesn't believe in antibiotics? Then you would have autonomy, patient self-determination versus beneficence, doing good for that patient. What if it's like chemotherapy and there's a lot of negative side effects that come with that prescription? That could be beneficence, doing good versus doing no harm, non-maleficence. What is the risk-benefit analysis there? Are we doing good? Are we promoting good, or are we just promoting harm? And justice, what if the medication was very expensive and the patient didn't have insurance? Well, that could be beneficence versus justice. We want to do good for this patient, but then we have structural issues that are preventing us from doing that. So recognizing which of these ethical principles are in conflict with each other and then managing this. The problem with this approach, it's called principlism. The problem with it is it's easy to identify which principles are in conflict. It's harder to navigate those principles. But we're really going to focus on the first two principles of beneficence and autonomy. So one of the most important aspects of clinical ethics and in the clinical scenario is patient-physician relationships. We want to be able to engage with each other, but then we have the problem with, we call it autonomy versus paternalism. Autonomy is patient self-determinations. Patients have the right to make their own decisions, to have their own experiences towards healthcare and understanding. But physicians are overly paternalistic. We don't want them to be paternalistic, but that's how that naturally comes across. Physicians are very educated, very knowledgeable, and to some extent know what good is done for the patient, know what they should be doing. But the problem becomes, do we take away patient understanding? Do we take away patient self-determination by forcing patients? We run into a lot of issues of our patients compelled in particular actions. Do we want to force them into things? What that comes down to between the two, is the importance of trust and what we call the shared decision-making model. The shared decision-making model is kind of a middle ground between autonomy. Patients are allowed, or I shouldn't say allowed, patients express their wishes, express their medical preferences, and then it's the physician who kind of builds that understanding. So we have, for example, like a patient who doesn't want aggressive measures. They want to be able to meaningfully interact with their family. They want to be able to meaningfully interact with their environment. If they're not able to do that, then they want aggressive measures to cease. That's not necessarily medical decisions. That's not necessarily yes or no, do I want ventilation? Yes or no, do I want a feeding tube? It would come to the physician to help make those decisions and to act kind of paternalistically in guiding that, but the patient sets those preferences, the larger overarching goals. But with that, coming back to our phenomenological experiences, patients, their experiences of things and their experiences of understanding create these medical preferences, and they create their the way they engage with their own care. And that's where we want to talk about with near-death experiences is, even if near-death experiences are not necessarily objectively true within a larger sense. They are very true to the individual patient. They are very true to the person who is experiencing that. We would say through a Herschel rationality that they have a true truth value, which means we have to completely respect that. We have to completely understand that. And while from a physician standpoint, there's always this education divide between patient and physician. Most people have a health literacy of around a 4th grade level, 3rd grade level as well. Being able to engage with patients is a challenge a lot of times because of the advances in medicine, the advances in technology. There's a good article called "It's the Ventilator's Fault." Before our advances in technology got to a point where we could do ventilation for a patient, we didn't have to engage with that. So technology creates these new scenarios, but that really changes the approach from less of a scientific and objective standpoint and more to a humanistic caring approach. And the most important thing of a characteristic of a caring approach is trust. Physicians have to trust their patients, understand, and patients have to trust their physicians to do what is in their best interest and actually value what their experiences are. And that is where, from my perspective as a bioethicist working with patients, now I have never specifically engaged with a patient who had a near-death experience and was using that as a understanding of their medical preferences, but we work with patients who have a lot of life experiences, a lot of pain experiences, a lot of family experiences that they build to that understanding. We have a patient who is 75 years old. The best way I teach medical students, I also teach attendings, so the whole gamut. When you have a patient who's 75 years old who is making a medical decision that you may not understand, as a physician, you may not recommend that, and you don't understand why that patient is making that decision, you have to realize our interaction with that patient may be 1 week. They've been in the ICU for 1 week. That patient making that decision has 75 years of experience to make that decision. And they are using every single experience that they know to, maybe not even consciously, but subconsciously, coming to that medical decision, coming to that understanding. And they really internalize the importance of all those experiences. And if we have these, going back to like the idea of everyday philosophies, you can either reject that patient's 75 years and say, we know what is objectively right, which, I mean, go into a meta-ethical argument, is there even objective right? But we don't act that way. And we ensure that we don't go that way. And I teach medical providers to not engage with patients that way. The most meaningful thing that we can say is, tell me about what you understand about your condition. Tell me about what you understand about your medical preferences. Explain why. We try not to pass any judgment or pass any stigma of the decision that a patient's making. I'm more interested in understanding, why are you making that decision? Because what can we achieve through other ways? An example is I had a patient one time who said that under no circumstance would they ever want to be kept alive by machines. No circumstance, never. And this patient had a pacemaker and was also receiving dialysis twice a week. That patient was very, very much kept alive by machines. So I could either reject that patient's experience, reject that patient's understanding, reject that patient's medical preferences because they don't understand, they're not informed, they're not educated enough. Or I can say that patient knows exactly what they want. That patient really trusts themselves and they really understand what kind of medical preferences they want. They don't understand how to express that to me. So what I did in that situation is I asked the patient, what does being kept alive by machines seem so bad for you? Why does that seem like such a low quality of life? And the patient thought about it and said, well, I'd want to be able to meaningfully interact with my family. I'd want to be able to care for myself. And I said, so it's not necessarily the state of being kept alive by machines, it's what you would be losing about that. And that's what the patient really accepted. So when we have these everyday philosophies being challenged, we have to reassess, where are we coming from? And we also have to trust that the patient knows what's the best decision for the patient. Is the sum up of all this talk. The patients really understand. And what we use, patients really build their understanding from their phenomenological experiences. So even if we don't have objective truth measures of experience, we have to trust that patient's experience. We have to trust that everything that they understand is true. And that is the most important thing for addressing these patients, because that brings dignity and respect and importance for those patients to be able to do that. My slides are not advanced. There we talked about this with quality of life. And the most important aspect of quality of life is it is not for patient or physicians to determine quality of life. It's for patients to decide quality of life. So let's go back to the situation of Michael. Just because the physician does not believe that Michael's experience of the ghost in the room is true does not mean that the truth value of Michael's experience is not true. Michael truly believed that there was a ghost in his room. That means it is true that Michael experienced that ghost, which means the physician has to respect that, has to understand that, and has to use that in putting in medical recommendations. So our closing thoughts. How do we understand life and existence and reality in our everyday philosophies? These can be challenged. These can be impacted by the experiences of our earth. By living our lives, we're always getting new information and we have our everyday philosophies. And it would be irresponsible to some extent to be stubbornly stuck with our philosophies and not trusting the experiences that we have, but also not trusting the experiences had by others. I have my everyday philosophies of how I believe the world works, and I have my experiences, but then you also have your experiences. And it is not necessarily my place to decide which of our experiences are more true, because both of us, they are very true to each of us. And what matters is how we address these. It doesn't matter about truth statements. That's a logical, fun thing. Cicero called logic the octopus that devours itself. It doesn't necessarily matter how true statements are. What matters is how we address them. And what my point of teaching about truth statements is it teaches respect for the patient, and it teaches the humility that we as medical providers should be approaching patient situations. We should be engaging with patients meaningfully on the level of the patient's understanding and the patient's approach. And life is understood and experienced by the individual. I am living my own life, you are living your own life. You have your own experiences, I have my own experiences, and we build our understanding of that through that experiences themselves. And that means we create our own truth statements. We create our own experiences, and the experience that I have had throughout my life is objectively true, has its own truth statement of true, and the same truth statements that you had are true and cannot be dismissed, cannot be devalued, and cannot be disrespected just because they may go against everyday philosophies. What matters is if you believe it's true, they are true within a logical structure. And it is fundamentally important for the physician to trust and respect patient autonomy, to trust and respect patients. And that is how we can have meaningful and engaging physician-patient relationships, and therefore meaningful and engaging patient situations in care. And those are my sources for my presentation.